and gentlemen.
Good morning, HAJIA.
Good morning, HAJIA.
Good morning, HAJIA.
Good morning.
We are doing well by grace. HAJIA and you.
Oh, thank you very much. Alhamdulillah. I'm also managing. I'm managing.
We thank God, HAJIA.
Alhamdulillah. Okay, thank you so much. Yeah, today, where did we get to the last time? We were on the Volva. If it is your group, the groups are many. That's why sometimes I ask, where did we get to? Where did we get to?
It's normal labor. We talked about physiology of first stage of labor.
Oh, I thought it's anatomy. You see, it's good to ask. Also, we are doing normal labor. Okay. Shall we hear somebody managing the first stage of labor? I think the other time, please, let's hear from you. Sometimes I just want to know whether, at least with your tight schedule, still you manage to go through what we have taught you, so that we can finish with the listen. Yes, anybody? Tell us how to manage the first stage of labor. We managed it well. So let's hear you. Should I mention names? Constance Afriye. Why you are showing your face so I can call you? Constance Afriye. Manage the first stage of labor for us. Don't behave as if you haven't heard me. Constance Afriye. That's your full name. Can you hear me, Constance? Yes, go ahead. Go ahead.
Complete. With the management of the first stage of labor, we use the mnemonic AHMED for the management of the first stage. And the D is for the definition of labor.
No, it was the physiology of the first stage of labor. That's where we do it. Physiology.
Good. I said you should manage the first stage of labor.
I just said you should manage first stage of labor.
That's what I said, Constance.
Oh, okay. But people were saying in the comment section that we have passed there. That's why. Sorry.
So they don't want a recap, eh?
No.
They don't want a recap. You can't be good teachers. Huh? Refresh your minds with what you did the other day, and then you connect it to the topic that you are coming to treat. That is how to teach. That is methods of teaching. So please, just link it. You have to refresh our minds. Somebody might have even forgotten about whatever we said, or maybe halfway. So quickly brush us through, please.
Please, we manage the first stage of labor with the mnemonic AHMED. So we talked of the definition of labor, which is labor is the process by which the products of conceptions they are expelled through the birth canal. And then we talked of the admission process. That's when a client comes into labor. With the admission process, you first welcome the client, and then you ask about the history. You welcome the client and ask about why she is there in the first place. You offer her a seat, and then you take the history of the client. You asked about the onset of labor, if she has ruptured membranes, if she has seen show, and all of that. You ask questions relating to the first stage. You take her vital signs. That is the blood pressure, the pulse, respiration. You do your urine dipstick. And you go on to the examination. Please, the O is the observation. With the observation, that is where the vital signs come in. Either you do the observation with your instrument or the senses. And we talk of the examination, that's the physical and vaginal examination. You do a head-to-toe examination of the client. You do the abdominal palpation, fetal auscultation, symphysiofundal height, and you check for the presentation too with the abdominal examination. And then with the vaginal examination, you position the client in the lithotomy position. You do the vaginal examination with your 2 fingers. And with the vaginal examination, you check for the dilatation of the cervix, the consistency, if the ischial spines are prominent, the condition of the vagina, if it's warm, if it's the condition of the vagina, if it's warm, which would depict warm or hot, which would depict maternal infections, or it can also indicate uterine rupture. That is with the vaginal examination. And please, with the actual management, that is the M. That is the actual management. After you've welcomed the client and done all your assessments, and after doing your vaginal examination and all of that, you have to feed the client. You have to manage her pain too. Pain management, you have to encourage her to empty her bladder and teach her how to take the midstream urine and all of that. To use the perineal pad, and when it falls, she doesn't use it again to prevent infections. That is with the actual management. And we moved on to talk of the investigations too. The investigations include the urine test, and you do your blood investigations, the HB, the hemoglobin or the FBC grouping and cross matching too. That is the few of the investigation you can do. And then the P is for the preparation towards the second stage. That's we talked of how to set the trolley, the top shelf and the down shelf. With the preparation, you have to set your tray. You set your tray by cleaning the top shelf and the down shelf with a spirit and a cotton. You clean your trolley with alcohol and cotton swab. You drape your trolley with the green towels, and you set up the top shelf and the down shelf. The top shelf, some of the things included the delivery set, that the sterile delivery set, which includes your forceps, your cord clamps, your surgical gloves, episiotomy scissors, dissecting forceps. And the down shelf too, we talk of the protective clothing, the protective clothes, yes. The down shelf too, you can include the extra baby stuffs on it, which includes the call sheets. The call sheet, if it's sterile, it can be on the top shelf. And then your pad, your bulb syringe, the pad and other stuffs, and you set up the resuscitation area too for resuscitation in case the baby is asphyxiated or something. Yes. Please, that's the little I can say about it.
You have done so well. Very, very well. Very well.
Thank
I'm
you.
so grateful. Thank you very much. Your name once again?
Please, Constance or say it freely.
Thank you very much. Okay. Now let's see the physiology of first stage of labor. OCFRE, that is your index number, okay? Yeah,
Yes.
somebody should tell us the physiology of first stage of labor. Quick one, then we can see. Who is ready to do that? Let me know your name. Yes, anybody?
Sister.
You, yes, sister. Your name, please.
Sister.
Hello,
My
I can
name
hear
is
you.
Asempa Enam Bernadette.
Okay, yeah, Asempa.
My name is Asempa Enam Bernadette.
Yes, please. I've seen it, yeah.
So, sister,
So
we
now
talked
tell
about
us.
the physiology of the first stage of labor. We talk about the physiology of the first stage of labor. And then we mentioned the points. We talked about fundal dominance, contraction and retraction of the uterine segments. We talked about development of the bag of waters, taking up of the service. So, sister, please, should I explain or I can just mention?
Oh, just mention them. Just mention them. We explained them, but there are some key.
And then we talk about
some key areas that we think we have to throw more light on. So when you mention those ones, you try to emphasize on it, and then those who didn't understand will now be able to grasp it. Okay. So go ahead. Something like the formation of bag of forward waters and hind waters.
Okay. So we talk about the fundal dominance. Then you said it starts from the side of the cornea, spread over the fundus, and spread to the other side of the fundus. Then the entire uterus receives the contraction. And then there's a muscular harmony between the upper and then the lower uterine segment, which is the polarity. And then there's retraction. And then there's retraction.
Ring.
Retraction ring.
Yes.
And then that one, it develops from the uterine contraction.
Whoever is doing this thing, please mute yourself. Please mute yourself. Mute it before I put you in the waiting room.
Oh, Emilia, please mute yourself.
Wait, let him prepare and the husband or in the waiting room. He's Emilia Watts. Emilia Watts. She'll go to the waiting room, no matter what. Benewa. The other time too, she did the same thing. Are you the only one having family? Emilia, if that is how you are going to behave, please go to the waiting room. Remain there. We are having lectures. When anything appears, any question appears there, you can't answer. And you will be the sufferer. Last week you did the same thing. This week you want to spoil the lectures for us. I won't allow that. Please continue. Please continue. The one
Sister, you talk about cervical effacement and dilatation. So with the effacement, the cervix becomes shorter, thinner, and softer. And the dilatation, opening of the cervix from 0 to 10 cm. And then formation of the uterine upper and the lower segments. And then the retraction occurs. This helps the cervix upward over the fetal head. And then they show that is cervical mucous plug mixed with small amounts of blood. And then there's rupture of membranes. Then it means the membranes will rupture spontaneously or artificially, and then it will release amniotic fluid. It also helps in the descent of the fetal head. So far. And then the formation of the whole bag of waters. The bag of waters, there are two, the forewater and then the headwater.
Great. Thank you very much. Let me admit this Benewa, because when we are getting to, if she doesn't get the information, she's likely not to pass the exams. And I don't want it that way. Let me admit it. When she comes back and she begins doing that, then I will know where to place her.
HAJIA.
Yes,
HAJIA.
sister. Yes, sister.
Please, I want to clear I want to clear myself on something before we continue.
Okay, go ahead.
Hello, Aja, can you hear me?
I can hear you.
Yeah, with the normal science, normal labor definition. So when you were doing what makes you know this is the actual labor, then you mentioned that when labor occurs between 27 to 40 weeks, then the lecture no, I've seen it is 37 to 42 weeks. So when I'm reading, I become confused, and I want you to clear for me.
You said I said what? You said I said what?
Yeah. So when we're taking the
No. I
definition
said
of labor,
what did we say? Definition of labor or normal labor. What did we say?
science of labor,
The
science,
premonitory science or science of labor.
science of labor.
Uh-huh.
So that is in. You said that when 10 pregnancy, 37 to 40 weeks. But when I came to the
What's
lecture
to
notes,
the
I've seen
please
42
take your
weeks.
time. Take your time
Okay.
and put your point clear so that we all understand. We said what to 40 weeks?
37 to 40 weeks of gestation.
Go ahead, we are listening to you.
Yeah, so when I come to the lecture note, I've seen 37 to 42 weeks. So that's my problem here. The 40 weeks and the 42 weeks is the one confusing me now.
You want to get
And
clear. So when a woman is pregnant
yes.
for 40 weeks, is she at term?
Yes. And when do we term it as post date?
And when do we term it as what?
Post date.
Post date or post maturity?
40 weeks to 42.
Yes.
37 to 40 weeks is term, and 40 to 42 weeks is post
2
date.
weeks is post date. Yes.
That means we
Maybe
have
that
to
is
correct
not.
it in the lecture notes. Because in the lecture notes, it's 42 weeks. That's where I'm saying.
Okay, but 40 is not post date or
Which lesson?
Yeah, 40 is not
like
40 is not post date. I know. Right.
So your problem now.
The post date actually ranges. It's a range. So if 37 to 40 is term, that is the range. Then 40 to 42
Please, do you
weeks.
remember when we're treating science of labor?
Hello. Hello.
Yes,
Yeah. Who is
yes,
speaking? Who asked the question?
Justina.
Justina who?
Stapak.
Okay. So Justina, your problem is
Yes,
after 42 weeks is post term or post maturity or post date. Is that it?
Okay.
And then
Yes, sir. Yes,
then your other issue is which one is post term or which one is the term?
No, not post term. Term.
Which one is term?
Yes.
Okay. I will answer you. Let me get you this scenario. We are talking about normal labor or term.
Yes,
And remember that from 37 weeks upwards going, somebody can be 38 weeks, 39 weeks, 40 weeks. So between this range, 37 weeks to 40 weeks, when the woman comes to labor, we consider her. Is that Binowa again? Binowa, Emilia, Binowa, is she the one?
Yes, sister. Yes, sister.
She has started again. Or is she the one? Let's continue. I don't think she has paid school fees. She hasn't. Okay. So I'm saying that from 37, 38, 39, 40 weeks is considered to be term. The woman is within the term period within which she can deliver at any time, and it's accepted to be normal. If she goes through the normal process, then we can consider that she has had a normal labor, or she's at term from 37, 38, 39, 40 weeks. Now, some books, I read it from, it's not Ojo and Briggs. I don't know, those of you who have been using Sheila, it's a very nice book. Sheila talks about 42 weeks and above. So from 42 weeks onwards, Sheila considers it as a post-term. She uses the term, it's an old book, so she uses the term post-maturity. Post-date is also accepted. Okay, I think that point is clear. Now, any date before the 37th completed weeks, we will say pre-term. Any date before the 37th completed weeks, we will say it is a pre-term delivery. Do you understand up to that point? So now,
yes, Ajia.
So now, if you want to talk about post-maturity, after 40 weeks, 41 weeks, 42 weeks and above, we'll consider it as a post-term pregnancy, where placenta degeneration will start developing. And as midwives, our concern is that once there's post-term, the danger associated with the pregnancy is that there's going to be degeneration of the placenta, where the maternal contact between the maternal surface of the placenta and that of the endometrium will be at risk. Why? Because there's something we call placenta infarcts will start developing. And so the circulation from the maternal uterus, let me put it that way, from the maternal side through the umbilicus to the fetus will be decreasing, or to some extent, it may be diminishing gradually. So I used to say that as a midwife, as a practicing, as a professional midwife, in fact, I have to be sincere with you. I fear post-term babies. I fear managing post-term babies more than that of a preterm baby. Though the complications of preterm babies are numerous, I fear post-term, because the post-term baby, because of placenta degeneration, after delivery, the baby is matured enough that most of the time they go into convulsion, they go into spasms, they go into twitching. Why? Because it's a matured baby and their glucose level tends to go down very fast as compared to the preterm baby. Their management, if you don't manage them well, it is hypoglycemia that will kill that baby, that post-term baby. Apart from the fact that they are subject to intracranial injury, they are subject to intracranial injury because the skull bones are grown, they are hard, will not permit overlapping, and there's direct pressure on their brains. So I think I've answered your question. I've added more information to it. Are you okay? Or your
Yes,
question is
Ajia.
too
Thank you so much.
Yeah, okay. Then you are welcome.
I'm okay.
Well, okay.
Thank
Okay.
you.
Okay. Then let's move on. So the lady who gave us the physiology of first stage of labor, please, I've forgotten your name.
Asempa Enam Bernadette.
Very good, Asempa. I'm so grateful for the information, how you briefly told us. Is good. Thank you very much. So now that we are done with the management of first stage of labor, we have known the physiology of first stage of labor. I'm putting just one question to you. I'm asking you just one question to see if you did understand it very well. The invisible ring I'm referring to the physiology of first stage of labor, the invisible ring, which sometimes overstretches. It overstretches and then attains the name bundles ring. Initially, it's called A, development ring, B, constriction ring, C, retraction ring. What will you choose?
C.
Retraction ring.
Retraction ring.
Retraction ring.
Retraction ring.
Retraction ring.
Okay. Thank you very much. So I know wherever you meet this question, thank you. You will do justice to it. Thank you very much. So at least you have understood all that we have said about physiology of first stage of labor. Now let's see. We have prepared the delivery trolley. The other day, if you remember, we mentioned all the items that should be on the trolley. The sterile items should be on top, while the clean items should be on the lower shelf of the trolley. I want to get one person preparing the delivery trolley so that this already prepared delivery trolley will be pushed to the best side. We are going to manage the woman during the second stage of labor, but we want to refresh our minds on the preparation, the items that we have to need. The midwife, how she will prepare herself, very, very important, because we don't want to introduce infection to the woman who has opened her vulva to our vicinity. Okay, so somebody should tell us the items, mention all of them on the trolley. How you set the trolley? How do we set it? Teresa, yes, hear you. Teresa, let's
HAJIA,
hear you.
please. HAJIA, please. I have a question, not to answer your question. Please. I was reading on the physiology of the first stage of labor. HAJIA, I got confused with the general fluid pressure and the fetal axis pressure. Please, can you explain that for me a little bit?
Yes, I can explain it to you.
Okay,
General
thank you.
fluid pressure and fetal axis pressure. Which one do you want first? Okay, let me take it from this angle. When we
Both.
talk about, you say both at the same time. Okay, so when we talk about fetal axis pressure, when you read it from the book, what did you see? What did you come across?
Sir, the general fluid pressure, no, it was talking about the effect of contraction on the amniotic fluid. And the fluid pressure was also talking about the effect on the fetal, is it axis or something? And I'm confused. But the fetus is in the amniotic fluid. So why is it that it's different from the pressure on the amniotic fluid and the pressure on the fetus?
Okay, let me explain it to you. Now, when we talk about general fluid pressure, first you should understand the functions of amniotic fluid before you can understand what you are talking about. So let's start from there. One of the major functions of amniotic fluid is that it receives the shock and the jolts of contraction. That is one thing you should bear in mind. That once the amniotic fluid is there, anytime there's contraction, the waves of contraction will be received by the amniotic fluid so that it wouldn't have direct pressure on the fetus. And this explains why we say, don't you rupture the membranes until the cervix has dilated 10 cm. That is the main reason. So that there wouldn't be direct pressure, compression from the contraction to the fetal body. I hope that point is clear. So the general fluid pressure, the fluid that is surrounding the fetus, once there's contraction, the pressure will be contraction. When it comes, it is received by the amniotic fluid. Generally, fluid pressure. So amniotic fluid is receiving the entire pressure from the contraction without having a direct impact on the fetus. Now let's see, when there is general fluid pressure, is not there, if the fluid is not there, if it is not receiving the general contraction, what happens to the fetus? Fetus receive direct pressure from the contraction. And I think the other day I made you to use a fix, make a fix and put one hand on it to determine contraction. I don't know whether it is your group. Is it your group?
Yes, HAJIA. Is this group?
Very good. Yes, it's this group. So that this type of contraction, if it is having direct impact on the fetus, where do you think will be the fate of that fetus? A fetus that was in a fluid, general fluid surrounding it, receiving the shock from the contraction. Now fluid is no more. So you can imagine, it is just like when we are playing with somebody and the person attempts to hold your neck. You see how your eyes will be widened, will be widely opened. You'll be suffocating. That is exactly what happens to the fetus. So the general fluid pressure is there to receive those pressures so that fetus will stay alive. Now, the fetal axis pressure, remember, if the fetus lies longitudinally, then the long axis of the fetus will be in line with the long axis of the maternal uterus. In that case, when there's contraction, remember, contraction and retraction, we said the uterus, the upper uterine segment contracts strongly and it will act like a pistol, pushing the baby down. Whilst the lower uterine segment, which is formed by the cervix and then the isthmus, will contract and dilate. And it will help to receive the fetus down so the fetus will come out. Now, we are talking about fetal axis pressure in such a case that when the fetus is lying longitudinally, then it is effective. So that the pressure from the fundus will compress on the fetal axis, the long axis of the fetus will be compressed and fetus will move down. Where there's contraction and retraction of the lower uterine segment, dilating, then it will allow the baby to come out. Now, imagine the fetal axis pressure. The fetus is lying transversely. Now, there's contraction, the axis of the maternal uterus. That one remains longitudinal all the time. So imagine that there's contraction. Fetus is lying transversely or obliquely. Pressure is coming from the fundus of the fetus. Though amniotic fluid is intact, will it have any effects on the fetus? No, it's a general question. It wouldn't. No. It wouldn't. Why? Why wouldn't? Why will it not affect?
Because the long axes are not in direct proportion with where the uterus is contracting.
Great. Thank you very much. So now you see the importance of the fetal axis pressure. It is effective when the fetus lies longitudinally. Then it will facilitate, it will promote the descent of the fetus. While if the lie is not in proportion to that of the uterus, then you end up having prolonged labor. You end up having obstructed labor. Then you end up rupturing the woman's uterus. So you see, all these physiological things that are taking place, it is important. It will help the fetus as far as normal delivery is concerned. So if it is normal lie, then the fetus wouldn't experience any difficulty. If it's a normal lie, where normal lie is longitudinal lie. But if it is abnormal lie, like we just used the transverse lie, then of course, it will affect the process of labor. It will affect the fetus, it will affect the mother. The entire delivery process will be abnormal. I hope I've explained it enough. Can we make a headway? Can I continue the one who asked the question? Do you understand it now?
Yes, sister. But sister, you see, you were saying that it is not advisable to rupture the membranes before 10 centimeters. But
Exactly.
Yeah, but my grandma is also saying that the fetal axis pressure is more significant if membranes have ruptured. So does that mean if the membranes are intact?
Did they give, wait, did they give the degree of cervical dilatation?
No, sister.
Mm-hmm. Mm-hmm. It wouldn't give the degree of cervical dilatation. Uh-huh.
Okay.
So now you get the point.
Yes, sister. Thank you.
Yes. You are
Thank you.
welcome. You are welcome.
Sister.
So that is it. Hello, sister. Go ahead.
Sister, please, sometimes too at the ward, when the mothers come and then their membranes are not ruptured, the midwives mostly rupture with the notion that when the membranes are ruptured, it facilitates quick cervical dilatation.
You.
So does that mean that we are not doing the right thing, or it is the same?
Madam, that is why. Thank you very much for that question. I'm happy that you have brought this up. And madam, let me tell you, that is the more reason why you are upgrading your academia. That is why you are doing the top up. That is why you are learning new things. So do apply them, please. There is no textbook. That's why the lady asked the question, and I asked her whether Margaret Mann gave a range of feelings cervical dilatation at which you have to rupture the membranes. No. So let me tell you, leave the mothers and their membranes intact. The word is intact. Leave them. Don't rupture it. And if you want to, you see, these are some of the things that we can use for research. You can try it yourself. When a woman comes into labor and membranes have not ruptured, don't rupture it. And time the duration. You just time. After all, you write it on the photograph. The time the woman came to the labor ward, you write it on the photograph. Fine. And then don't rupture the membranes and see the duration of a labor. See how long the labor will last. Now, if a woman comes, another woman comes, you don't try to rupture the membranes, but say the woman has ruptured the membranes spontaneously. That's why you cannot say whether the woman was fidgeting with a service or whatever, and then the membranes got ruptured. So let's say she has ruptured membranes spontaneously before she came. And then time the labor, time the duration of labor, and see how long it will last before she delivers. And then you continue monitoring the amniotic fluid, the smell of the liquor, if infection has not set in. Monitor the woman's vital sign to see if she wouldn't spark fever, if the temperature will not be rising because of early rupture of membranes. So you see, the complications of rupturing the membrane outweighs when the membranes are intact. Just give yourself a try and observe and see. Then you yourself will say it's HAJIA. You see it. So that is how it is. Yes, sister.
Please, as she said, we should try it. I also did some last week when you taught. This week I decided to try it to see.
Okay.
So a client came the day before yesterday at 9:10. When I did my assessment, she was 4 cm and membranes have bulged already, so I left it intact. Then around 10, the client was like, she feel like she's going to toilet. I was like, I 4 cm, how can she just progress? Like, but when I went in there, she was 8 cm. So I was trying to set up my things. The time I realized baby was coming.
You see?
In my former facility, we like augmentation to the extent that even other was even complaining that we augment clients. But after these lectures, I tried it and it worked perfect. Just an hour, the client did it.
Thank you very much. I'm grateful to share this experience with us. Thank you very much. You see, that makes midwifery dynamic. Just keep on changing. And then give yourself a try. And then you will see. Because the membranes, once intact, it will serve as a wedge. It serves as a protective means. It serves as I don't know the word to use again. It's like you spread your arms When you are spreading your arms, what happens to when you bend your hands and you are spreading them? You bend your hands, bring your hands together, your fingers, like you are clapping, and then bend your hand. You see the position of your shoulders, your elbow. Have you seen the position? Are you trying the position of your shoulders? Why am I using shoulders for elbow? The position of your elbow. So the elbow is acting as a way of expanding, pushing in no time. So that is why we are saying that just maintain the integrity of the patient by respecting her, by making the patient feel that you care so much about her, by making the patient feel that she's in safety hands, she's in good hands of obstetric team, and you are readiness to help her. In that case, things will follow the normal routines, and then she'll be fine. She will deliver in no time. Okay. Okay. So that is it. Those things that you are writing, I want to read them, but it goes off as soon as it comes. It goes off. So if you want to see it or read it yourself, you can read to the whole class and they will all hear. So that is it, ladies and gentlemen. Let's forge ahead. You are saying something important, but that is okay. So that is it. Now let's move on. The ready prepared delivery trolley. I said somebody should summarize the items on the trolley, and then we'll push it to the best side. We are going to deliver the baby. But remember, the fetus will have to go through mechanism of labor. The fetus will have to go through what we call mechanism of labor. And it is the mechanism of labor that the midwife will have to follow. Once you know it, that is what the midwife will have to follow to deliver the baby. Eunice Mensah, do you have any concern to share? Eunice Mensah, do you have any concern to share with us? Do you have a question that needs clarity? There is a Mensah. Yes. Before we move on to the mechanism of labor, please, if you have anything, just say it. What we've been written there is what is written there is not readable. It's like in no time it goes off, so you can't read it to the fullest.
HAJIA, please, one of them said, is sweeping of memory helpful?
Yeah, in some those of you who have been sweeping people's memory, that painful procedure that you have been inflicting on patients, what do you say to that? That's so painful, a procedure. In some facilities, one today will sweep your memory. And how do you do it in the first place? Very, very painful. Membranes that are adhered to the cervical, you say membranes, you have to detach yourself. Detach yourself from the cervical wall. How do you do it?
By force.
I'm saying, no. By force. How do they do it, please? How do they do the sweeping of the membranes?
So HAJIA, when we are mostly the doctors ask us to do it. We
How do you do it?
Somebody who has delivered before automatically has a multi-port. So you insert your fingers inside, then you try to push it a little harder. Then you are going round small, rotate your fingers little by little. That is how we do it to initiate
or to start labor.
Okay. Now, have there been an instance where, in an attempt to sweep the membranes, you end up rupturing it? Be sincere to yourself. Has there been
No,
an instance like
no,
that?
please. Me,
No,
I've not
it
no.
doesn't happen like that. Unless you
Okay.
intentionally want to rupture it.
Rupture it, yeah. And now that you know the dangers associated with early rupture of membranes, I don't think you even try. That's why in
No.
midwifery we say we don't leave our fingernails overgrown. Don't leave your fingernails long. As if your fingernails are long enough, it can easily tear the membranes and then you rupture it, which is very bad. Okay. So, yes, sister.
Haja, good morning.
Good morning, Auntie Gladys.
No, please, this Rabia too.
Rabia too. Oh, okay, go ahead.
Yes. Haja, please, I wanted to share an experience concerning rupture of the membrane.
Okay, go ahead.
I had a client who was in labor. She came around 8:30 a.m. So when I did, after assessing her everything, when I did the it was 9 c.m. Her membranes were bulging. I just quickly ruptured it, expecting her to deliver by 8:45, 9. But it got to 9:10 and she was not delivering. Labor was not progressing again. I augmented. And membranes were bulging again. So I became confused and I re-ruptured it again. And as the fetal head had descended, the head went back. So I couldn't even tell the presentation.
The head went back. It went back to where?
It went higher. It was not,
okay.
Yes. Sorry for the.
Okay.
So I became confused. I didn't even know the presentation again. So and it was getting to 11:12. So I just quickly referred the woman to the next hospital. So I followed her. When we went there, they also did their examination. They couldn't get the presentation. We're all confused. Finally, doctor, she was just about to push in sent to the theater, and she just pushed the baby out.
I see. Interesting. I see. One. What actually?
Okay.
Uh-huh.
I
Okay,
just
it's possible.
thank God that this woman has finally delivered. Because I was afraid. I was scared.
Miraculously. I see. I see. It's sometimes you get some interesting cases like that, but then it's possible that when you rupture the first membranes, some of you, when you are rupturing membranes, you don't go down. You don't go down. What I mean by you don't go down is, the amnion hook, you should enter posteriorly. You should go down before you tear the membrane. But some of you don't do that. If you go down and you rupture, the membranes, the liquor will never splash on you. One thing you should know. The liquor will never splash on you. Some people rupture membranes and everybody, whoever is standing closer will get a share of the splashing of the liquor.
It's true. It's
Yeah,
true,
thank you very much. Thank you.
They'll
Thank you
just
very
go to
much.
the top where the membranes are bulging and tap on that place.
Exactly. You do that and you will splash your face. You get every item there will get contaminated from the liquor of the woman. But it shouldn't be like that. You should put your hand down, straight down, getting to the rectum. I'm not saying go and rupture membranes in rectum, but I'm saying that posteriorly, then you tear the membranes. Before you use your hands, to separate the membrane from the presenting parts. And remember, When you do that, you don't take off your hand. You don't remove your hand. Your hand should still remain in the vagina. Please take note. Your hand should still remain in the vagina. Why? Why? Because you don't want the hind waters. You remember the bag of forewaters and hind waters. You don't want the hind waters to sweep the umbilical cord out as it is coming. That is why after rupturing the membranes, you leave your hand inside there. So that the liquor is coming, though it's coming with pressure, but because your hand is there, it will be seeping alongside your hand, and the rate, the speed will be reduced. So your hand is there to control the pressure, to control the speed at which the membranes is, the fluid is using to come out. So that is it. So in your case, it's likely, it's possible that you might have ruptured the membrane from wrong direction. You see, and that is why probably it wasn't properly ruptured, probably. And that's why there was a second sort of membrane covering. But if you hadn't ruptured the membranes, you would have attained the cervical dilatation that you wanted. You see, at long last, the woman delivered per vaginam. Finally, she delivered per vaginam. So she would have delivered at your facility there if you hadn't ruptured the membranes early. So you see, I'm happy that people are now getting the essence of maintaining or preserving the membranes till second stage of labor. So let's quickly go through the mechanism of labor. Yes, can somebody quickly tell us? Somebody, anybody, those who have unmuted themselves. I'm calling one of them. Adam. Those who have unmuted, you have unmuted yourself. So talk. Adam, why are you now muting yourself? I'm calling you to tell us the mechanism of labor. Olivia, you see, they are running away.
Mister, let me see it.
Hello.
Say it, my dear. Your name, please. Your name.
I'm Daniel.
Oh, Asempa, thank you very much. Go ahead.
The mechanism of labor, it refers to when how the fetus undergo the process of labor through the birth canal. So they are about 9 points to note. So we have the engagement. We have the descent, the flexion, internal rotation, the crowning, the extension, restitution, external rotation, and then expulsion. That's for the explanation. I'll leave it for you to do it.
You have really done well. Thank you very much. You have done well. Thank you very much. Okay, then let me quickly take it. Let me quickly take the mechanism of labor. The definition is that, please, those of you who will be following the slides, the mechanism of labor is not on the slides, pardon me. But today I will teach you for you to understand. Without even looking into any book, you can still understand it, please. So the definition is that it's a series of passive movement, which the fetus undergoes during its passage through the birth canal. I'm saying it again. It will not be the same wording, but that is the meaning that matters. I'm talking about mechanism of labor to be a series of certain passive movements. You see, the fetus makes some movement before it finally, passes through that bony canal. It's a bony canal, a bony place, a bony space that the baby will have to manage itself and pass through it to come out. So that's why we say it is a series of passive movements which the fetus undergoes during its passage through the birth canal. So the first one is descent. like she said. Descent takes place throughout. At any point in time, baby is descending. At any point in time, baby is descending. Why is it descending? Any idea, anybody, to tell us why the baby, at any point in time, it is descending? Yes, any idea?
HAJIA.
Anybody?
Because
Yes,
of the
sister.
fetal axis
Please.
pressure.
Because of fetal axis pressure and
Traction. Traction and retraction.
contraction and
Contraction and
retraction. Very good.
traction.
Very good. Because of fetal axis pressure that comes about as a result of contraction and retraction of the uterine muscles. So we are saying that
And sister,
descent
also the
takes
normal
place,
presentation,
the normal
like
presentation,
the
good,
longitudinal.
lie.
Yes.
So we are saying the lie is longitudinal. The lie is longitudinal. Then attitude is one of complete flexion. The attitude of the baby is one of complete flexion.
AHMED.
All the time. Hey.
AHMED. Me pass on her dear mommy one. Me want
Yes, attitude to the next step.
Mama, so good morning.
Sister Ruth.
Bo, are you
Sister Ruth, can you please mute yourself? Na mama me na sen try the man. Why?
Ben me was something.
What is her name? What is her name? The one making noise. What's her name?
She has muted herself.
Okay. So we are saying that a normal mechanism of labor, descent takes place throughout. And as the fetus is descending, there's increased flexion. Baby tries to flex itself in such a way that it will be able to maneuver its way through this bony canal. So there's increased friction, descent is taking place. Then once descent takes place, baby comes to the pelvic brim, where what we call internal rotation of the head will take place. I hope you are jotting down the points. You are jotting down the stages. I've told you already, mechanism of labor is not on the slides, but I'm teaching you, so you can also jot down the points that I'm mentioning to you. So descent is taking place, there's increased flexion, then there will be internal rotation of the head. Every point that I mentioned, I will tell you what happens. Any stage, what happens to the baby? Why is the baby assuming that posture? We'll talk about that. So internal rotation of the head. Now, with the internal rotation of the head, it is the occiput. We are talking about normal labor. So the occiput is always the leading part. Occiput is always the leading part. So the occiput being the leading part will meet the resistance of the pelvic floor muscle first. Please, I'm doing right occipital anterior. Mechanism of right occipital anterior. And it will be opposite the left occipital anterior. Okay, so with the right occipital anterior, the occiput is the leading part, and it will first meet the resistance of the pelvic floor muscle first. Then it will make a rotation. It will rotate towards the left side, left thigh of the mother. Then the occiput will come and lie under the symphysis pubis. Is it clear? Can I continue?
Sister, can you take it
Yeah,
again?
can you take it
I
again?
said the occiput is the leading part. Now, the occiput, as the baby flexes the head, baby flexes itself so that the chin of the baby would be touching the chest. Baby had already folded arms on the chest. It has bent the thighs on the abdomen, and it has bent the legs on the thighs. So imagine a baby assuming this attitude. So that is why we say attitude is one of complete flexion. Baby has flexed itself very well. So this flexion that it is going to use to pass through the birth canal. But because it has bent the head so well that it is the baby's occiput that takes the lead. The occiput becomes the leading part. So occiput, as it enters the pelvic, the pelvic floor muscle, it enters obliquely, where obliquely means it is using the diameter called the sacrocotyloid diameter or sacrocotyloid dimension. It measures 9.5 centimeters between the promontory of the sacrum and the iliopectineal eminence. So that is the diameter the baby is using to enter. Now, once it enters, then the pelvic floor muscles that line the pelvis will then receive the push, the pressure that the baby is using to enter. Then the pelvic floor muscles will direct the fetus. Say, hey, madam, turn yourself. Turn yourself, make it 1/8 rotation. Go and lie under the pubic arc. So the baby, we are saying that once the baby enters with the occiput will meet the resistance of the pelvic floor muscles first, then it will turn 1/8 of a circle. Then the occiput will come and lie under the symphysis pubis. I think I've explained it enough. Now, crowning will take place. Crowning will take place. With crowning, the head no more recede with contractions. What I mean is, with crowning, the head does not go back. It does not go back with contraction. Like somebody shared her experience that at a point when she ruptured the membranes, the head rather went out. I was just, you see, I was laughing when she mentioned that. Crowning has not taken place. So where do you think the head should go? It will go back. That's why when she said it, I was just laughing. Probably she might have forgotten about mechanism of labor. So we are saying that with crowning, the head does not recede. It does not go back with contractions. Those of you in the delivery ward, you see, sometimes you ask the woman, you see there's no cervix felt around the head. You ask a mommy, you push. The woman pushes, and then when she stops pushing, the head that was advancing, that was coming, then goes back. I'm sure those of you who, all of us, when you observe delivery for the first time you saw a baby coming from the vagina, how did you feel? When the woman was pushing, she stopped pushing, and then the head goes back. Hey, as if you should also push for her. When the woman is pushing, what do you do?
We have been pushing.
Don't you also push?
Yes,
you have been pushing. No push, yes. She's pushing, you are also pushing. At that moment, your panties is soaked with urine because nothing is coming. You are forcing yourself to push. You urinate. Dribbles of urine will come into your panties because we call it a reflex action. It's a reflex act, yes. It's normal anyway. So then, but then when crowning takes place, it means that the biparietal diameter of the fetus, that is the longest transverse diameter. If I were you, I would write this thing down. Meaning that the longest transverse diameter, that is the biparietal diameter of 9.5, has distended the vulvar outlet. It has distended the vulvar outlet. So there's no way the head will go back. So that there's no way the head will go back. Then you say crowning has taken place. So, madam, the one who said the head at a point, you saw that it was coming later, it went up. Crowning didn't take place. At that time, crowning didn't take place. That's why the head went back. It will go back if there's no crowning. And it is at the crowning that every midwife will have to give an episiotomy if there's the need. It is at the crowning and not at any point in time. So crowning has taken place, and we are saying that with crowning, the head no more recede with contraction, or if you like, the head doesn't go back with contraction. Then crowning has taken place. After crowning, then extension of the head. Crowning is followed by extension of the head. And with extension, what do we say? With extension, the sinciput of the baby, that is the forehead, the face of the baby, and the chin or mentum will sweep the perineum. They will say extension has taken place. Remember, it is a mechanism this baby is doing by itself. It's a mechanism that the baby is doing it by the help of the peripheral muscle. It is doing it by itself. Midwives are interested in the mechanism of labor because it will serve as a guide for us to conduct the delivery. Can I continue? Can I continue?
Yes,
Okay.
Ladies and
yes,
gentlemen, very good. Now, after extension, then followed by restitution. Once the baby extends the head, restitution will then take place. And with restitution, I'm explaining restitution. With restitution, the baby turns its head. In fact, some books are saying 1/8 of a circle. So somebody is saying, so crowning is part of what? She says, so crowning is part of internal rotation of the head.
Yeah.
Internal rotation of the head takes place and it is followed by crowning. They are all part of the mechanism of labor, but one precedes the other. So the head will have to, internal rotation of the head will have to take place first, followed by the crowning. Let him continue. So we have, after crowning, then we have extension of the head. With extension, the baby extends the forehead or the sinciput, the face, and the mentum. That is the chin. Will then sweep the perineum. Now, baby will do what you call restitution. Where restitution means baby will turn the head slightly. We are doing right occipital anterior mechanism. And so the baby will turn the occiput slightly towards the right side of the mother's thigh or the mother's pelvis. Slightly. Why is it restituting? It is restituting to undo the twist in its neck. It is doing that to release the traction in its neck. That is what we mean by restitution. Now, once the baby restitutes, the head turns slightly towards the right side of the mother's pelvis. What happens internally? Let's see. So at least we are all sure, 100% sure, baby's head is out. It's left with the rest of the baby body. Let's see how the rest of the body will also behave. Now, because of the restitution turning 1/8, the shoulders of the baby will be in the left oblique diameter. I'm saying it again. I said because of the way baby has turned its head slightly outside. Then the shoulders will be in the right, in the left oblique diameter, so that the anterior shoulder of the baby becomes the leading part. The anterior shoulder of the baby becomes the leading part. So that part, the anterior shoulder, will meet the resistance of the pelvic floor muscle again. Then it will rotate 1/8 of a circle along the left side, of the mother's thigh. Now the shoulders will come and lie under the symphysis pubis. So take note, anytime baby makes a turn, it brings the baby forward. It makes the baby to assume a particular posture. So now with the internal rotation of the shoulders, shoulder turns and it will be in the anterior-posterior diameter of the pelvic outlet. And because of that, it leads to external rotation of the head. Remember, the head is now in the oblique diameter with its restitution, bringing about the internal rotation of the shoulders. So you yourself try it. Turn your head slightly. Please, I want you to demonstrate it yourself so that you can appreciate it better. Please demonstrate it yourself. Ready? We are all going. Turn your head slightly so that you are also able to point to the right side of your hand. Now, turn your head, your shoulders. So as you are turning your shoulders, let it move along with the head. You are turning the shoulders to be in the anterior diameter. Your shoulders are now in the oblique diameter. Please do it so that you can remember. So the shoulders are now in the oblique diameter. And the anterior shoulder, at this time, the anterior shoulder will be your left hand. It is now hitting the pelvic floor muscle. It is rotating. So rotate yourself and see how your head will also rotate at the same time. So rotate. Go. We are all going. We are all going. We are all going. Turn your shoulders, your head. So did you do it or you didn't do it? Hello?
I did it.
I we did.
We did. We did that, yeah.
We did it, Mom.
My left
Good.
hand was in me and the right was around the symphysis pubis.
Yes. Yes. So as you are turning the shoulders, you see your head will also be turning at the same time. Your head is turning at the same time. And now you see your shoulders are now in the under the symphysis pubis. The shoulders are now under the symphysis pubis. And you see the head has also turned at the same time. So that is why we said internal rotation of the shoulders will lead to external rotation of the head. Internal rotation of the shoulders will bring about external rotation of the head. So now the anterior shoulder is now the leading part. So it will now escape under the symphysis pubis. Then the posterior shoulder will sweep the perineum. Then the rest of the baby, the rest of the body of the baby will then follow the curve of Caros and will be delivered laterally towards the mother's abdomen. That is all about mechanism of labor. That is all about mechanism of labor. So, ladies and gentlemen, the gentleman among you, I only saw his name once. Hardly will he talk in class. Don't do that. We are among these plenty women and you don't want to talk. Okay. So that is mechanism of labor. We are talking about descent takes place throughout. Then flexion also takes place. Then we said internal rotation of the head will take place, followed by crowning. And then after crowning, there's extension of the face or the head. And we said with the extension, the sinciput, the face, and the chin will sweep the perineum. Then follows by restitution. After restitution, then there will be internal rotation of the shoulders. Then after the internal rotation of the shoulders, it is followed by external rotation of the head. Then the rest of the baby will be delivered by lateral flexion onto the mother's abdomen. So, ladies and gentlemen, that is the mechanism of labor. And this mechanism is going to serve as a guide for the midwife to conduct the delivery, so that you don't get up and then because the head is out, like some of us do. Because the head is out, oh, she's even doing the internal rotation for the baby. They are turning the baby to the right. Meanwhile, it is left to speak to anterior. They get hold of the head and they are delivering the baby, and now the shoulders are stuck. Hasn't it been happening to you? The shoulders become stuck because you didn't wait for the restitution to complete. You didn't wait for external rotation of the head, indicating that internal rotation of the shoulders had taken place, and you want to pull the baby out. You cause perineal tear. Most of the perineal tear that the mothers have been sustaining, it is the fault of the midwife. But we tend to, accuse the mother. Madam, I told you, put your buttocks down. You didn't mind me. See how you have turned your buttocks. See how the degree of tear, perineal tear that you have sustained. You are accusing the mother for nothing. Accuse yourself. Blame yourself, oh, my dear midwife. Blame yourself. You are the cause. You are the cause. Okay, so ladies and gentlemen, let's be patient and let the mechanism of labor serve as a guide for us to conduct our delivery peacefully. Peacefully. Okay, so the mechanism of labor, HAJIA has this song that she has formulated, following it critically, so that in an examination, if I ask you, rearrange the following mechanism of labor in order of occurrence. You don't come and tell me that restitution is the first one. You don't come and tell me that lateral flexion of the body, because I will mix them up, and then probably the lateral flexion is even the first. Maybe internal rotation of the shoulders is the first. But you will have to arrange them. And I have formulated this song so that once you are singing it in your head, you can easily arrange them and get your full mark. Are you interested in it?
Yes,
Are you interested in it?
yes,
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 I'm interested.
Yes, Hadia.
Yes,
yeah.
Okay.
Hey,
So
hey.
if you know how to sing it, keep quiet.
Yes,
Others may not know,
HAJIA.
so that every member of this platform will grab it very well and will not fail any examination when the question is asked on mechanism of labor. Okay, so it goes like this. Descent, flexion, internal, rotation of the head, crowning of the head, extension of the head, restitution of the head, internal rotation of the shoulders, external rotation of the head, lateral flexion of baby. Okay, so that is the mechanism of labor and its song. Any question?
Hey.
Any question? Hey, say.
HAJIA, please, the song
Hello.
again.
Okay. 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 So I said it goes like this. But I've mentioned the steps all together already, so I don't need to go over. But I've formulated the song. So it goes like this. Please, the one making noise, mute yourself. Mm-hmm. Christina Pra. Christina Pra. Don't let me put you in the waiting room. Christina Pra. She's not ready to mute herself. Christy, mute yourself. Patience, mute yourself. And you be mute yourself. If you don't mute yourself, I'll mute them for you. And then if you unmute, that's where I'll put you in the waiting. Ajubu, I've muted you. You have to unmute yourself, eh? So it goes like this. Descent, flexion, internal, rotation of the head, crowning of the head, extension of the head, restitution of the head, internal rotation of the shoulders, external rotation of the head, lateral flexion of baby. So that is it. I'm done. Hello, ladies and gentlemen.
Hi.
Hello,
Hi, dear.
Okay.
Haja, please
Do you want do you want us to sing together in a chorus
Yes,
form? Some
Haja.
will start
Yes.
and some will be
Yes,
ended. But
please.
it doesn't matter. Once you take part in the singing, you can still remember to write. So
Okay.
descent flexion internal 1 2 sing.
Descend,
That is it.
internal
Rotation
rotation
of
of
the
the
head,
extension of
Of
external
of the head. Institution. Of the internal rotation.
rotation of the head,
External rotation.
external rotation
Of baby. Hey, somewhere and then somewhere beginning. That's how it is. It is. So, Nuhu Rabiatu. Just give us the song so that we can remember. You alone. Nuhu Rabiatu. Sing it.
Rotation of the head,
Nuhu
crowning.
Rabiatu. But that's starts. Descend, stretching, internal. Nuhu, go ahead. 1
Please, the
2
rest of you,
sing.
mute yourselves, please.
Mute yourself. Let Nuhu. Let Rabiatu sing. Rabiatu, 1 2 sing.
Madam, please let Sister Giti help me.
Madam, I can sing.
Who are you? Who are you? Is this
I'm
Teresa?
not ready.
Yes. Who is ready to sing? One person, only one person. Yes.
Okay, Sister, please, I want to sing it. Okay.
Sing it.
So,
Go ahead. Go ahead.
Descent, flexing, internal rotation of the head, crowning of the head, extension of the head, restitution of the head, internal rotation of the shoulders, external rotation of the head, lateral flexion of body. Thank
Hey,
you.
clap for her, clap for her, clap for her, clap for her. You have done well. Clap for her. You have done well.
Haja, please, I have
Okay.
one question to ask.
Okay. So that is it. There.
Haja, please, I have one
There. Okay, go ahead. Ask your
please,
question.
during crowning, we mostly
Uh-huh.
ask the women to stop pushing and then give to their mouth. I want to know the reason behind it.
Okay.
Please, we
She's
can't
saying
hear
that she said during crowning, mostly the midwife for conducting the delivery will ask the mother to stop pushing at that time. Yes, that is why we are saying the mechanism serves as a guide. At crowning, remember, the head will not recede. It wouldn't go back with contractions. And so it will come out definitely with the mechanism that we just learned. After crowning, what happened? There's extension of the head. And so we have this in mind that we are going to extend the head. So if you ask the woman to continue pushing, what happens is that she pushes and the head is popped out. The head will come out forcefully without passing through the extension process. And that is what calls the perineal tear. I've answered you, and I think I've answered you perfectly. At crowning, don't let the woman push. Like we say, mommy, stop pushing. She's stopping pushing so that you will get hold of the bitemporals of the baby and then aid their extension so that the chin will not cause perineal tear. That is the reason why we say, mommy, stop pushing. Other than that,
next month.
other than that,
Please question.
other than that, what will happen is that the head will pop out forcefully and the baby may end up with tentorial tear. That is a tear in the tentorial cerebelli behind the occiput. Or because of the force of pushing, baby will use the chin to pass through the perineum and cause a perineal tear. Because remember, the chin is bony. Everybody's chin is bony. So baby will use that bony part, that is the chin, to make a pathway. Because it is at the crowning that you would give an episiotomy if there's the need. But you ask the woman, continue pushing, and the worst thing will happen. Meanwhile, if you had given a straight episiotomy cut, you would have sutured it nicely without any perineal tear. The one who asked the question, I think I've answered you. Have I?
Yes, please, HAJIA. Thank you.
Sister.
Okay. Yes, sister.
Sister,
please, my hand is up.
Sister, please.
Somebody.
My name is Juliana.
Hey, yeah, no.
Before crowning or takes place, sometimes when you are delivering the baby, we are told to maintain flexion before crowning occurs. And sometimes when you are delivering before crowning, the baby's head moves back, which is I want to know the name given to that mechanism. Because initially I was thinking that was restitution. The baby's head is going back means restitution, but I've gotten a different meaning here.
No.
So I want to know the mechanism for that movement of the baby going back before crowning.
You want to know the name? Or
yes, please. The question is, before crowning takes place during
mechanism.
delivery, yes.
Hello?
We are told to maintain. Sister, can you hear me?
Yes.
Hello. Yes.
I can hear you. Please go ahead.
So the question was, before crowning takes place during the labor, during delivery, we are told to maintain flexion before crowning takes place. And during that process, sometimes the baby's head goes back. As you explained that when crowning takes place, the baby head will not move back. I want to know the name given to that mechanism there.
Where the head goes back?
Yes, please.
Oh, the head is going back. We said because crowning has not taken place. Remember, we said it is the pelvic floor muscles that is causing the resistance. So there's resistance of pelvic floor muscle taking place at that time. And that will cause the baby, yes. It is the pelvic floor muscles that are so rigid, they are firm. They don't want the baby to pass through the perineum at that time. And so they redirect the movement of the baby. And that is why the baby makes a 1/8 turn, a 1/8 rotation to come and lie under the symphysis pubis. That is what that happens. So it is from there, that movement, that rotation, that the head will come and lie under the symphysis pubis. That 1/8 turn, if that is what you want to know, it makes a 1/8 rotation to come and lie under the symphysis pubis. And that's where we say, then up there and then crowning will then take place. So that the head will not go back. It will not go back with contractions. And remember, once the pelvic floor muscles are resistant, contractions are still taking place. Contractions are still taking place. But yes.
When does the fetal station come in? Is it at the descent?
Oh, fetal station. Please, what we are doing is a mechanism that the baby is doing by itself. The fetal station can be assessed by the midwife. Station minus 1, 2, 3, 4, station plus 1, 2, 3, 4, 5. using the ischial spines. You will do it. It is during delivery. It is during delivery. That one has something to do with the delivery process itself, with vaginal examination itself. But this one is a mechanism that the fetus is undergoing without anybody helping it. It is just between the mother's pelvis and the baby. That is why some people say that, somebody said that without you, the mother can deliver. So let's avoid the way we communicate to them, the shouting and then the maltreatment. Because without you, she can still deliver.
Yeah.
But this mechanism is learned so that it will guide us to conduct a meaningful delivery without subjecting the woman to any laceration. So the one who wants to know what goes on, that is what goes on internally.
Thank you, sister.
We call the whole thing mechanism of labor. So there's no specific mechanism apart from the mechanism of labor that we are talking about. Okay. People's hands are up. Sophia.
HAJIA, please, I wanted to know if flexion engagement is the same as crowning of the head.
No. Engagement is not the same as crowning of the head, even though it has some similarity. But engagement is, you can assess engagement by using abdominal examination, the descent. Engagement goes with descent.
Okay.
Engagement, yes, it goes with descent, but not crowning, no.
Oh, okay. Thank you very much.
So that you're welcome. So that you use what you call the fifths, using your 5 fingers when you are doing abdominal examination. They will talk about it during pregnancy, but I can still mention.
Okay, thank you, HAJIA.
So you use your 5 fingers to cover up the part of the fetal scar, the fetal head, abdominally. We assess the descent. Our time is getting up. They will take us any moment from. Is it 11 o'clock? Is what? Okay, let's continue. When they take us out of the distance, the Zoom, then at least the important points have been taught. I don't know whether we will manage. We'll deliver this video today.
11:15.
It's 11:15 that we are supposed to close.
Yes, sister.
Oh,
Yes,
then
sister,
let's move on.
11:15.
And the time now is what?
11 o'clock, please.
11
o'clock.
Then we can deliver this baby. Let's answer their
Yes.
questions and deliver the baby. If not, the baby is suffocating. We don't want to deliver any asphyxiated baby. Let's hurry up. Baby has been there since last week, so we have to deliver it. Those whose hands are up, I hope you have similar questions.
Someone was asking whether it's in precipitate labor, that's the mechanism okay?
Yes, with precipitate labor, mechanism takes place, but it is too abnormal.
Oh, okay.
It's so rapid. The mechanism will take place, but it's so rapid, it's abnormal. That's why precipitate labor, they are prone to postpartum hemorrhage. Uterus is doing things fast. Baby comes out and now uterus is tired. It can't contract again. The mother will start bleeding.
Okay.
So that is it. So precipitate labor mechanism will take place. You're welcome, dear. Yeah, those whose hands are up.
HAJIA, what of those that takes medication for the labor to speed up?
Yeah, it's the same precipitate labor. They end up.
Okay.
It's abnormal. It can even cause.
Yeah, please, I want to.
If we answer your question, you put your hand down so that we know the number of hands up. Right now, I have so many hands
Please, this
up.
is Mercy.
Mercy, what's
This
yes?
is also Mercy. Please, I wanted to know the difference between the restitution and the external rotation of the head.
Oh, the difference is that in restitution comes before the external rotation of the head. And in the restitution, we said baby turns the head slightly, depending on the position, whether it's the right hospital anterior or left hospital anterior. So it will turn slightly towards the right. If it is right anterior that we are managing, it will turn slightly, not complete, so that you see that the head will be in an oblique diameter of the vulvar outlet there. That is restitution. And we said it restitutes to undo the twist in the neck. Because baby twisted the head out, it came out. So there's still some traction in the neck of the baby, and baby will restitute to undo the twist. Baby will restitute to undo the twist. But then, external rotation of the head, we said it is internal rotation of the shoulders that will bring about the external rotation of the head. That is the difference. So that the head that was restituting in an oblique position, the head is in the oblique position. Now the head will
Please,
be in the
Hajiya,
transverse
we
position
can't hear.
of the head.
Yeah, we can't
So
hear you.
Can't hear.
can you hear me? Hey,
Yes, your
Yes.
line was breaking.
We didn't get the explanation,
oh,
please.
sorry. Oh, but as for the explanation, I even wanted it to come from one of you to her. Hello.
Hi.
Hi.
Can you hear me
Hajiya.
now? Okay.
Hi.
No, her question was, what is the difference between restitution and external rotation of the head? And I said that with restitution, when the head comes out, the baby turns just a little bit, about 1/8 of a circle, so that you see that the head will be in the oblique diameter at the vulva. But then there will be what you call internal rotation of the shoulders will take place. That will bring about the external rotation of the head. So the head that you were seeing it to be in an oblique diameter as restitution will now turn slightly further. It will turn further. And then that is where you will get the external rotation of the head.
Yeah.
The one who asked the question, is it answered? Have I
Hajiya.
Yes,
answered?
sister.
Very good.
Hajiya.
Yes,
Hello,
sister.
Hajiya.
Most of
Hajiya,
us
Yes.
good afternoon.
is like
Hajiya,
the moment
please.
the head comes out from the vagina, no. We the
Mhm.
midwives, so we do the restitution.
Is it even restitution? You do the
Yeah.
external rotation in addition for the baby. My goodness. You do
Yes, that's why I was asking.
it. Uh-huh.
Hey,
You do
Ajia,
it
aren't
for
we
the baby.
supposed to do
So
it?
ideally we have to
No,
wait
no, no,
for
no,
the
no,
baby
no,
to
no, no,
do
no.
the restitution, but we
Allow,
we are in a hurry, so we do it
you
and
are in
then
a hurry. So
we do
sometimes you
the
realize that
delivery.
when you attempt doing it, you do it and it doesn't succeed. You do it so the baby is not coming out. You have restituted
Yes.
it to the wrong position. Baby is coming with the left occipital anterior, and you are restituting, turning the head to the right occipital posterior. What do you think you are doing to the baby? You are part of the Ehlers palsy. You are part of the conquist nerve damage of the baby. Who is the call? Assemble Crane. Somebody is calling. Please let me pick the call. Oh.
Michelle.
Sisters, let's deliver our activated baby already.
Sisters, please, I have a question. Help me. Like yesterday, I counter heavy labor. Like the mother BP was 90/75, but it rise to 150. Then the fetal heart rate was 176. That was tachycardia. I'd rather just monitor it every 15 minutes. But because of the mother BP and the fetal heart rate of the baby, I didn't know the infusion that I'll connect that will help both mother and the baby. Please, can someone help me?
Please,
what
the
was your
BP, how
question?
many times did you check that she knew it was high? How many
I
times
didn't
did
hear
you
the
was
question. I'm interested in the question.
Ajia,
What did you do?
please.
Yes.
The initial BP was 75, 97.75.
Yeah.
The woman was in 6 cm dilated.
Mhm.
The baby heart rate was 176. So I was checking the fetal heart rate every 10 minutes because I was afraid. So I called my in charge and he said I should put NS, but because of the mother's BP, which is 176, I was confused. So I just connected.
So what?
I just connected the NS and monitored the fetal heart rate every 10 minutes. And the BP, I also reduced it to every 30 minutes. The contraction was 4 in 10, lasting of
60 seconds.
Yes, please. 50 seconds. So I was confused about the infusion that will help the mother and the baby.
So you think the BP was high, and so there was no need to set up the normal saline?
Yes, please.
What happened to the ringers lactates? You could have set up even dextrose saline. You could have, even if you had dextrose saline, dextrose, even plain dextrose could have even worked.
So I'm pleading you help me with the infusion and maybe this BP, you connect this one, this, like I was confused yesterday.
That's what I'm saying, that you should have set up dextrose to energize the woman and then the baby. I said dextrose.
Sisters, I think to save our own self, when the woman comes, you just give the ringers. You see, the ringers is both dextrose and the normal saline. So even if the person is rising BP or the person is running hypocra, the ringers will help.
Yeah. Okay. And that is the recommended.
Ringers has dextrose and normal saline.
Ajia, please, our previous discussion, I think you also taught us that sometimes the positioning of the mother can also affect the fetal heart rate. She was also complaining about the fetal heart rate rising. Yes, please. And our previous discussion, Ajia taught us that sometimes the positioning of the mother can also affect the baby's fetal heart rate.
Yes, exactly that, because when the woman lies in the dorsal position, remember, the inferior vena cava and the aorta, they are lying one on either side of the vertebral column of the mother. And so once the woman lies in the dorsal position, there's compression. The weight of the gravid uterus is compressing on these great vessels, and it will reduce circulation. It will reduce circulation to the placenta site, and people will exhibit it in a form of fetal distress. That is why sometimes you people will say that lie on your left side. Haven't you been telling them to lie on their left side? As to the rationale behind, you don't know.
We do.
For what reason? No, I'm saying that
was it correct for me to check the fetal heart rate every 10 minutes?
Every 10 minutes. Yes. That is the best. That is the best.
My in charge was say at least 15 minutes. Because I was
but 15 and 10 minutes is not any big deal. 15 minutes and 10 minutes is not any big deal. So that this time around, it wouldn't come to the protocol, but you have to indicate it.
He said that I was also disturbing the mother, timing the listening to the fetal heart rate continue. I was also disturbing the mother, which will also rise in the BP. So I was confused. I didn't talk. So I said I will ask earlier.
15 minutes was quite okay. 15 minutes was quite okay. Was he a primiparous or multiparous woman?
She was primiparous.
She was a primipara.
Yes.
Has he delivered before?
No.
She was a primigravida, madam.
Primigravida, yes, madam.
Technologies, we have to be careful.
Hey,
she was a primigravida. That's a part. I asked them all.
She was a pregnant
HAJIA,
gravid.
please, our
You mean she
baby is
hasn't delivered before?
suffocating. Asphyxia is setting in.
She's,
The baby is blue now.
she's already asphyxiated. But the way it is, this baby will
We
have
are
to remain
prepared to
in
bag
the
the
vagina, in the
baby.
uterus
We
for you see. But people were asking
So
their
prepare
questions.
the
I have to.
suspension table so that when we deliver,
Um,
we'll receive the baby.
we'll set up the delivery.
Let's inform
So
MBU
so let's
before we deliver.
okay. So I think the questions have ended, and since they haven't taken us off, let's try to deliver the baby before it becomes severely asphyxiated. So now the delivery trolley, the already prepared delivery trolley, management of second stage of labor. In fact, we can't deliver this baby today because we haven't spoken about physiology of second stage of labor. Have we? Have we?
No,
I'm asking
HAJIA.
you.
No,
We
sister.
haven't.
No,
So
please.
the baby will remain there. Let it remain there. And then we talk about physiology of second stage of labor. What is the physiology? Physiology of second stage of labor. And then we haven't even mentioned signs of second stage of labor. Oh, this poor baby. Even though mechanism is studied, we'll still leave the baby in utero. Okay, so let's see. What are the physiological changes in the second stage of labor? Anybody? Those whose hands are up. Frida, Aposu. Oh, she's
Yeah,
dodged.
yeah.
Yes. Yes.
It's one part of the mechanisms of labor.
You say what?
Molding. It's molding
Molding.
part of the mechanism of labor. Yes, please.
You said, you're asking that is molding part of the mechanism of labor. No, please. No, madam. Molding stands on its own. Molding is where there's alteration in the shape and size of the fetal head during its passage through the birth canal. Molding is not part of the mechanism of labor. It stands on its own, but then there's interconnection. It has some connection with the delivery process, but it's not, we don't mention molding as part of the mechanism of labor. Did you see that somewhere?
No, please.
Did you come across? Okay. You wanted to know. No, molding stands on its own. That's why we have different types of molding. Okay, thank you. So, physiology of second stage of labor. Abigail Awura, tell us that you mentioned their name and they will run away. Abigail, why do you run away? Okay.
HAJIA.
Okay. Yes.
Hello, HAJIA.
Yes, I'm
Please,
listening
the
to you.
physiological changes in the second stage of labor is where the continuation of the same force which occur in the first stage of labor, but the activity is accelerated. And we have three factors that contribute to the physiology of the second stage of labor. We have the uterine action, that's the first one. And the second one, we have the soft tissue displacement. And the third one, we have the mechanism of labor.
Okay.
That's what I can say.
Okay, so then let's pick the first one. Pick the first one and elaborate on it. Hello? Let's pick the first one. Yes, sister.
Oh, okay. The uterine action. The uterine action is where the uterine contraction becomes stronger and longer, but less frequent.
So you call it expulsive uterine contraction. So the uterine contractions become very expulsive. Go ahead.
And this allows the fetus and the mother a period of rest and relax. It allows the fetus to expel from the uterus. Because of when there is continuation of contraction and retraction of the upper uterine segment, it thins and dilates the lower uterine segment. And so this results in the rupture of membranes at the end of the first stage or the onset of the second stage.
Abigail, we are telling your husband to keep quiet. You are in lectures. You are in the lecture hall, so tell your husband to leave you alone.
Adia, please, it's not me or my husband is not around.
But who is that gentleman talking in your room there? I think some cry. Okay.
Adia, please, another person, they have on media, so maybe it's from their end. So the
Okay.
media says.
Okay. Thank you. Okay. So, talking about the physiology of second stage of labor, like she said, there's changes that goes on. The changes that go on in the uterus. Then there's displacement of the pelvic floor muscles. Please, we are looking at the structural changes at the anterior aspect of the baby. And then structural changes at the posterior part of the baby. I'm talking about the presenting part during second stage of labor. So the contraction and the retraction of the uterus is obvious, but this time it is intensified. It is so painful. Even though it was painful, it has become so severe at this time because the upper uterine segment is trying to push the baby out of the uterus. The lower uterine segment is also ready to allow the baby to come out. That brings about the explosive uterine contraction. Now let's see. At the anterior aspect of the presenting part, I'm talking about the stretches above the presenting part. Remember, we have the bladder. The bladder, though, is a pelvic organ whose child is now taking over from me. Whose child? Please, Abigail Kweku, tell your child to go away. You are in the lecture hall. You should go and sit somewhere and leave you. So, Abigail, better. So, what I'm saying is that the bladder lies at the anterior aspect of the presenting parts, superiorly. So, bladder, though is a pelvic organ, will now go up. It will move up per the uterine contractions and the descent. The bladder will now move up to become an abdominal organ. If you remember very well, during pregnancy, the bladder behaved the same way. When the gravid uterus came to, filled up the pelvic cavity at that time, the bladder, remember, made several attempts to empty itself to pave way for the gravid uterus. That brought about frequency of nutrition.
No, after.
Priscilla, mute yourself before I put you in the dark waiting room. Priscilla, mute yourself. When we say mute yourself, you don't want to mute. What is it? Okay. So I'm saying that the bladder behaved the same way during pregnancy. When the uterus was growing, they were all sharing the uterine cavity. The pelvic cavity. But when the bladder realized that uterus has now become pregnant, it was pressing on itself. So let me empty any content in me or bladder. Let me urinate so that let the woman urinate plenty so that at least the growing fetus will get a place to occupy. Now that the fetus is ready to come, it has descended back into the pelvic cavity. The bladder is there again. This time the bladder said, no, I'm not going to empty myself. I will run away and give you this full space. I hope you are getting the physiology. So bladder would then leave the pelvic cavity and come to the abdominal cavity. It doesn't want any trouble. And it is at this time, remember, when the bladder is moving from the pelvic cavity to become an abdominal organ, it moves along with the urethra. It moves along with the urethra. And that explains why the woman cannot urinate during second stage of labor. And that explains why, when I'm teaching and these people are doing this, I don't like it. You disturb the class, you disturb, oh God. And the interest in the distance, they kill it. Because I have to stop and be telling them to mute themselves. Better. Okay. So I'm saying that when the woman, when the bladder, when the bladder feels that the uterus the head has descended to the pelvic cavity again, if it were you, will you stay there? No. So the bladder will now be thrown up to become an abdominal organ. And as it goes up, it moves along with the urethra. So then the urethra, as it is being pulled up by the bladder, the lumen of the urethra now is occluded